Good morning, everyone. Respected Emeritus Chairperson, Sir, Dr. M.L. Sonkar, Sir, VC, Sir, Dr. Gulati, Sir, Principal, Sir, Dr. Andy Soni, Sir, other dignitaries, dear colleagues and students. So today we are going to present a CCR from the Department of Orthopaedics. And before we start case presentation, let me give you a brief overview of the Department of Orthopaedics. We are 6 professors, 2 associate professors, 6 assistant professors, 5 senior residents, and as on today we have 33 residents. So our PG started in 2009 with 2 seats, which increased to 3, 6, 9, and since 2024 we are having 12 admissions each year. We have 2 dedicated orthopedics operation theaters which are equipped with fracture table and C-arm image intensifiers. The number of patients coming to orthopedy are steadily increasing. In the last calendar year there were over 44,000 patients, and this year till May end there are over 21,000 patients. Similarly, the number of surgeries show an increasing trend. In last calendar year we had 1375 surgeries, and till May end this year there are 723 surgeries. The surgeries done in our operation theatre mainly are arthroplasties, hip arthroplasties, which were 116 last year, knees were 131 last year, we did 4 shoulder arthroplasty cases, and arthroscopy 204. So all these numbers are steadily increasing each year. So now let me give you a glimpse of some important and interesting cases in the orthopedic subspecialties. So like this patient with brachial plexus injury and a comminuted fracture upper humerus was treated with 2 long plates to stabilize the fracture, and brachial plexus injury was also treated surgically, and patient had a good outcome. This case, acetabular fracture, complicated acetabular fracture with hip dislocation, was also having sciatic nerve injury. So this was stabilized using 3 pelvic reconstruction plates, and at the same time the hip was also reduced and the sciatic nerve injury recovered conservatively with conservative treatment. This interesting case was a compound open fracture femur, 1-month-old, neglected, with a large segment of bone lying outside the wound. So we had to excise this protruding bone and then stabilize the bone with an Ilizarov fixator, where the bone lengthening was also achieved with bone transport. The patient had a good functional recovery. Crush injuries of the fingers and hand with multiple fractures were treated with a jazz fixator, which has an advantage of doing dressings conveniently, at the same time stabilizing the fracture, and the patient has a good outcome. In arthroplasties, we are doing all types of arthroplasties: total hip replacement, cemented as well as uncemented, and in some cases where dislocation is a risk issue, we do dual mobility. So a dual mobility THR was done in a residual paralysis case. In early knee osteoarthritis, where only the medial compartment is involved, we are doing unicompartmental knee arthroplasty. Shoulder arthritis with rotator cuff redundancy, we are doing reverse shoulder arthroplasty, and in suitable cases we are doing simultaneously bilateral total knee replacement. Arthroscopies most commonly done for shoulder rotator cuff repairs, and for the knee there are various ligament injuries that happen so frequently these days with sports injuries. So ACL reconstruction is also one of the very commonly done procedures. So we have done some rare cases like meniscus transplant surgeries, where we use semitenuous tendon to replace the meniscus. So in spine also we are doing discectomies, decompressions, and stabilization using the pedicular screws. So in pediatric ortho cases also, deformities we are correcting. This case was a resistant rigid club foot, where we use a jazz fixator and we have a 12-year follow-up of this case when both feet are identical without any deformity. So in bone tumor cases also, this was a case of right scapula Ewing sarcoma where we had to do scapulectomy. This second case was a large giant cell tumor of the upper tibia where we had to did an extended curettage and filled the cavity with bone cement. Then there was a case of fibular head sarcoma where we had to do excision of the upper fibula. As far as academic activities are concerned, every day we are having an hour of academics where the department, all residents, faculty sit together. We either hold a seminar or a journal club meeting or a case presentation, or we have group discussions. We evaluate residents' knowledge through quarterly internal assessments. We do invite eminent faculty members from outside to deliver guest lectures, and they interact with our faculty members as well as the students. We do hold model-based learning sessions for the students where they are learning about arthroplasty or arthroscopy or advanced trauma on bone models. And we regularly hold grand ward rounds where the teachers, where the students are involved in bedside teaching, case discussions, and how the case are being managed and what are the different plans of management. We have live surgery CMEs. We have also had different medical colleges of Jaipur involved in an inter-college PG seminars also. As far as publications are concerned, we had 44 publications in PubMed index journals and 63 publications in UGC care list recognized journals. So with this I come to end this presentation and will request Dr. Vikrant Katariya to proceed with the case presentation. Thank you.
A very good morning, respected Emeritus Chairperson Sir, Vice Chancellor Sir, esteemed faculty members, my seniors, colleagues and residents. I welcome you all today for this combined clinical rounds by the Department of Orthopaedics, where we will be discussing a case of a 60-year-old male with right hip pain. So a 60-year-old came to us in OPD, a resident of Mandor, Jaipur, who had chief complaints of pain in right hip since 8 months, limping since 8 months, swelling around right hip region since 4 months, and patient was unable to bear weight since past 1 month. Coming to the history of presenting illness, patient experienced pain 8 months ago, insidious in onset, in front of right hip region. It was dull aching in character, progressive in nature. Initially pain was mild, it worsened to moderate and then severe. Pain increased on movement and it was partially relieved on taking analgesics available over the counter. Patient also had associated limping, which was gradual in onset since 8 months with dull aching pain. Patient started with stick support 1 month post onset of symptoms, and patient is on walker support since past 3 months. Patient also noticed diffuse swelling 4 months ago around right hip region, which was gradually increasing in size, not associated with onset of fever. Also he noticed thinning of same side thigh muscles, and patient was unable to bear weight for the past 1 month. Patient didn't have any history of trauma, no history of fever, weight loss, anorexia. Patient also didn't have any complaint of multiple joint pain and morning stiffness. Let's come to the personal history. So patient is a shopkeeper by occupation and he took analgesics over the counter for pain management. There is no significant past history associated with the patient, and our patient is a vegetarian by diet, also a chronic smoker with history of 10 packs per year. There is no significant family history associated with him. Coming to general physical examination, Our patient had a weight of 100 kgs and height of 170 centimeter and hence body mass index of 34.6 kilogram per meter square. Rest all the investigations and the examination were within normal parameters. Coming to the local examination, our patient had walker-assisted antalgic gait, and patient was examined in standing, lying, and sitting position from front, side, and back. Further evaluation was done in supine position with the right lower limb held in slight flexion and external rotation at hip joint. Coming to inspection, we inspected diffuse swelling present over anterolateral aspect of right hip region of roughly 12 by 18 centimeter. The overlying skin was stretched and glistening was observed. There were no scars, no sinuses present over the swelling. Our patient had a flexion deformity at right hip joint which was observed during inspection. Also, wasting of ipsilateral gluteal, thigh and calf musculature was present. We also observed flattening of gluteal folds. On palpation, a diffuse swelling present over anterolateral aspect of right hip region which is irregular in shape, having indistinct edges, irregular margin, and also size was confirmed which was taken during inspection. Our swelling had local rise of temperature and it was tender on deep palpation with irregular and rough on surface. Also, the swelling was fixed to the underlying structure. The swelling was hard but yielding in consistency. It was non-reducible, non-pulsatile. Also, the skin present over the swelling was pinchable. On examining the movements, flexion deformity was observed of 10 degrees at right hip joint. Also, the range of motion was painful with terminal restriction of movement. Our patient had flexion from 10 to 50 degrees with painful flexion from 50 to 70 degrees. Extension was 10 degrees short of extension. Also, the internal rotation was markedly reduced during examination. There were no neurovascular deficits associated, and examination of contralateral lower limb and both upper limb were normal. Coming to the measurement, there were no limb length discrepancy. Also, we measured a difference of 6 cm in thigh girth from the contralateral side, hence inferring presence of wasting of muscles. Also, there was a difference of 5 cm in calf girth from the contralateral side, hence again there was wasting present of calf muscles as well. Coming to systemic examination, all the parameters were within normal limits. There were no discrepancy found in the examination. So let's quickly jump into the summary for this patient that we have so far. We have a 60-year-old male with 8-month history of progressively worsening right hip pain, which was aggravated by movement and partially relieved by analgesics. There was progressive swelling which was hard, irregular, with deep tenderness and local rise of temperature. It was associated with limping, requiring walker support since past 3 months like we just discussed. There was wasting of ipsilateral gluteal, thigh and calf muscles. Flexion deformity of 10 degrees of present at the right hip joint. And our patient had walker-assisted antalgic gait with no distal neurovascular deficits. So let's quickly discuss the possibilities that we can have. Anyone from the audience, what are the possibilities that you can come up with? Yes? So neoplastic. Okay. Right.
So arising from where? Arising from femur, arising from pelvis? According to the examination shown to you, where do you think it is arising from? Upper femur.
Any other possibilities? Inflammatory. Okay. Any other possibilities? And degenerative? Probably. Let's see. So we have a 60-year-old male with right hip pain since 8 months with muscle wasting, flexion deformity, no fever, no trauma. First, quickly discussing the neoplastic possibilities. In primary bone tumor, we have a saying in Orthopaedics Oncology: a primary bone tumor is rare after the age of 40 until proven otherwise. Why? Because a destructive bone lesion in an older adult should be considered metastatic disease or multiple myeloma. In metastatic disease, the points in favor is age 60 and the history of smoking. However, no known primary tumor is found in the patient. In the inflammatory pathologies such as rheumatoid arthritis, seronegative spondyloarthropathies, the points in favor is flexion deformity with global range of motion restriction. However, we haven't found any morning stiffness, no polyarthritis, and the presence of localized swelling is completely against the possibility of inflammatory pathology. Next, infective pathologies such as septic or tuberculosis of hip. The points in favor is monoarticular hip involvement and the history of smoking. However, the patient was afebrile throughout the symptoms and there were no sinuses or scars present over the swelling. In degenerative pathologies, the factors in favor of osteoarthritis is painful and restricted range of motion. However, the rapid progression of symptoms from the past 8 months and also the swelling characteristics go against the possibility of osteoarthritis. For avascular necrosis, the factors in favor again is progressive nature and restricted range of motion. But the factors against is the age 60 years, the swelling characteristics and no risk factors associated such as steroid use, alcohol abuse or history of trauma. So the next we investigated X-ray for the patient of pelvis both hip. As you can see, this is a skygram of patient showing pelvis with both hips in antero-posterior view. As you can see, there is a lytic lesion over weight-bearing area of acetabulum and right iliac wing. Also, we can see breach in iliopectineal line, suggestive of breach in cortical continuity of anterior column, indicating pathological fracture. At age of 60, lytic lesions is indicative of myeloma. However, during general physical examination, pallor was absent, hence inferring absence of anemia. Still, we would like to undergo a few investigations for the patient to rule out myeloma. So first, we got an CBC done for the patient, which showed slightly raised ESR. We also investigated serum calcium, serum phosphorus, parathyroid hormone, and alkaline phosphatase for the patients, and all the investigations were within normal limits. We also investigated liver function test for the patient because total proteins is increased in myeloma. However, in the investigations, total proteins as well as alkaline phosphatase were within normal limits.
So total proteins is not increased, the globulins are increased, right?
Yes.
As a consequence, total proteins may be increased. But the specific abnormality is a monoclonal increase in the globulins.
M proteins, yes. Next, we investigated renal function test to see the creatinine level.
These are T1 axial sequence images showing a large expandile hypointense lesion measuring approximately 9.1 into 6.5 into 5 centimeter, showing involvement of lower aspect of right iliac bone with internal and outer cortical breach. Involvement of upper fibers of obturator internus muscle is seen. No involvement of neurovascular bundles is seen. In the stercoronal images, we see involvement of superomedial right acetabulum and extension up to the subchondral aspect of acetabulum with hip joint involvement. In the T2 sagittal image, we can see involvement of iliacus and breach of iliac cortex. So the final radiological impression is as follows. Aggressive osseous tumor with soft tissue involvement and extension into the right hip joint. Imaging differentials are chondrosarcoma, multiple myeloma, osteosarcoma and metastasis. I now invite Dr. Vikrant to take the case further.
Will you call this multiple myeloma or will you call this plasmacytoma? Because you don't see lesions anywhere else. So more likely a localized myeloma, which is a plasmacytoma. Agreed?
Yes. No sir, in plasmacytoma we will see geographical lesions, also sclerosis is present, and we don't call it multiple myeloma because multiple lesions are present in that usually.
So did you see multiple lesions here other than this side?
No sir, there is one lesion over here. Also in multiple myeloma there will be multiple punched out lytic lesions. Thank you sir.
Thank you, Dr. Anukriti, for highlighting the findings in MRI. So, post-radiological assessment, the findings are suggestive of malignant etiology involving right iliac blade, right anteromedial and a part and anterior column of acetabulum, part of right ischium, obturator internus muscle and iliacus muscle. Now, after evaluation of MRI and having malignant etiology, what further investigation would we want to get done? Anyone from the audience? So looking at the size of the lesion, we advised USG guided biopsy, which was done by interventional radiology team and was sent to Oncopathology team for further evaluation. To highlight the findings in the biopsy, I call upon Dr. Kusha Sharma from Department of Oncopathology to take the case forward.
Good morning, respected teachers, colleagues and residents. I will be discussing the histopathological aspects of this case. So we received a specimen of USG guided biopsy from the right iliac bone mass, which comprised of linear tissue cores ranging in length from 0.5 to 0.8 centimeter. Microscopy revealed tumor cells which were spindle to ovoid and undifferentiated and which were arranged in diffuse sheets, and we could also see brisk mitotic activity along with the presence of atypical mitotic figures. Interspersed multinucleated giant cells were also seen. So we employed immunohistochemical studies to basically come at a diagnosis, and the tumor cells were diffusely positive for vimentin, which signifies mesenchymal origin of these cells, and the tumor cells were negative for CK7, CK20, ruling out epithelial origin, CDX2 ruling out colorectal and upper GI origin, SATB2 ruling out osteosarcoma, S100 ruling out adipocytic neural cartilaginous origin, SMA, Desmin ruling out the smooth muscle origin, CD45 ruling out lymphoma, and finally HMB45 which ruled out melanoma. So the final impression given was high-grade sarcoma of undifferentiated type. Now I would like to request Dr. Vikrant to proceed further.
Thank you, Dr. Kusha, for highlighting the findings of the biopsy. So far, we have a patient with high-grade undifferentiated sarcoma involving right iliac blade, anteromedial part and anterior column of acetabulum, right ischium, obturator internus muscle, iliacus muscle. Now, what we need to do is to stage this sarcoma. For this, we ordered a PET CT to be done for the patient. Requested PET CT to be done for the patient. So this is the report of the PET CT showing FDG avid lytic expensile osseous lesions with associated extraosseous soft tissue component in right iliac bone and roof of right acetabulum, giving a likely picture of metastatic disease, and there were no other metabolically active lesions involved. So, by musculoskeletal staging system, also called Enneking staging, our patient had high-grade sarcoma with extra-compartmental involvement and no metastasis, hence put in the stage 2B. Under AJCC TNM staging, the tumor was high-grade with more than 8 cm size, no nodal involvement and no metastasis, hence stage 2B. So, the final diagnosis that we have in our hand is a 60-year-old male with pain and swelling in right hip with high-grade undifferentiated sarcoma involving right hemipelvis of grade stage 2B. Being part of the prestigious institute such as Mahatma Gandhi Hospital, we were able to set up a multidisciplinary tumor board consisting of medical oncology team, surgical oncology team, orthopedics team, radiology team and oncopathology team. The plan of action that was decided in our case was to first give neoadjuvant chemotherapy followed by surgical management. Quickly discussing the points in favor for giving neoadjuvant chemotherapy. It reduces the tumor size and soft tissue involvement, It treats micrometastatic disease if present in early stage. It also facilitates limb salvage and wider surgical resections. To take the medical management further, I call upon Dr. Pranjal Sindhu from Department of Medical Oncology to take the case forward.
Good morning, respected Emeritus Professor, teachers and my dear colleagues. So this patient, 60-year-old male with diagnosis of high-grade undifferentiated sarcoma of right hemipelvis, stage 2B, was referred to us after discussing in MDT, and he was planned for neoadjuvant chemotherapy followed by disease assessment. Baseline pre-chemotherapy evaluation was done, including 2D echo, hemogram, biochemical investigation. So the rationale for using neoadjuvant chemotherapy in this patient was presence of high-risk features, including high-grade sarcoma, tumor size more than 5 cm, deep-seated pelvic tumor, undifferentiated pleomorphic sarcoma, and potentially morbid pelvic resection. So patient received all 6 cycles of neoadjuvant chemotherapy, including doxorubicin and ifosfamide. These were given for a period of 3 days, every 21 days. He tolerated 6 cycles of chemotherapy well without any chemotherapy-related toxicity. After completion of the chemotherapy, patient was advised PET-CT for the response assessment, and he was referred back to Orthopaedics department for further surgical management. Now I would like to invite Dr. Vikrant to take the case forward.
Thank you, Dr. Pranjal, for highlighting the medical management in form of neoadjuvant chemotherapy. So the post-chemo PET-CT reports done in the month of February 2025 and April 2025. The image in the leftmost is pre-chemo PET-CT done in the month of November 2024. As you can see, these are 3D PET maximum intensity projection images showing large area of focal uptake in the right pelvis region in the leftmost image, which decreases in intensity in post-chemo follow-up scans. These are FDG avid-lytic expansile lesions with significant soft tissue component, which was noted at right hemipelvis involving the iliacus, ischium and right acetabulum. Post-chemotherapy, the subsequent PET-CT scans done for response assessment are showing decrease in FDG uptake and size of the lytic expansile component. Now for further surgical planning and to assess the tumor further, we requested MRI post-chemotherapy for the pelvis to be done and also NCCT pelvis with 3D reconstruction. To highlight the findings, I call upon Dr. Anukriti from Department of Radiology to discuss about post-chemo MRI and the CT scan.
Good morning. On comparison of pre-chemotherapy and post-chemotherapy images, we see reduction of lesion size from 9.1 into 6.5 into 5 cm to 5.3 into 5.5 into 4 cm with interval reduction of soft tissue components. The extent of edema in iliacus muscle has also reduced. Here, the involvement of obturator muscle is seen to have resolved on diffusion-weighted imaging. Post-contrast sequence shows central necrosis within the lesion, which is consistent with post-chemo tumor necrosis. This is an axial T1 weighted image in which there is no involvement of sciatic, obturator and femoral neurovascular bundles. Therefore, pre-chemotherapy and post-chemotherapy changes are as follows. There is 39.5% reduction in tumor size. Also, in post-chemotherapy scans, involvement of obturator internus muscle is not evident. Therefore, there is partial radiological response to chemotherapy. I request Dr. Vikrant to take the case further. Okay. CT was done by orthopedics team for correlation and for bony landmarks for surgical planning. In addition to the already above mentioned findings, we can see areas of internal ring and arc calcification which represent chondroid matrix mineralization and subchondral bone loss in the superior aspect of hip joint consistent with joint involvement. Thank you.
Thank you, Dr. Anukriti, for highlighting the findings. So, patient was discussed again in the multidisciplinary tumor board post partial response to chemotherapy. Now, surgical management was undertaken for the patient. In surgical options involving in right hemipelvis with such a large tumor, we always go for limb salvage. The only indications for amputation are unable to achieve negative margins, limb with poor line base function, local recurrence, and involvement of neurovascular structures. None of these indications were present in our patient. Hence, we decided for limb salvage. Before discussing the options that we have available with us in limb salvage, we need to undertake what is the portion of the right hemipelvis that needs to be resected. For that, we have Enneking and Dunham classification of pelvic resection, and by the help of MRI and CT scans, the zones involved is zone 1 and 2. Hence, a large part of hemipelvis has to be resected. Now, briefly discussing the options in limb salvage. First, arthrodesis. It is a salvage procedure with fusion of femur to pelvis. It gives us a stable painless hip, but at the cost of hip motion. The next option that we have with us is meshplasty. It is a biological reconstruction procedure where mesh reconstruction of acetabulum is done. It bridges the pelvic defect at the cost of hip stability. The next option that we have with us is megaprosthesis. In this, a prosthetic replacement of pelvis or hip is done. It offers us immediate stability with mobility. Now let's discuss why we didn't consider the options of arthrodesis and meshplasty. In arthrodesis, it would have resulted in loss of mobility, and in our case, the extensive bone loss like we just discussed in Enneking classification would result in inadequate bone stock for fusion. Also, poor functional outcome and cosmetic limb length discrepancy were against the favor of arthrodesis. In meshplasty, loss of stability at hip joint, inadequate soft tissue cover for mesh reconstruction, limited durability. Also, our patient being obese with a BMI of 34.6 kg per meter square is not an ideal option. Also, the higher risk of infections is associated with meshplasty. So, we went with megaprosthesis. Why did we consider it in our case? Inadequate bone for biological reconstruction. Also, megaprosthesis provides immediate structural stability and allows early mobilization. It restores limb length and enables better function and quality of life. Modular system allows custom reconstruction of pelvis, and it is oncologically safe, which means it facilitates wide margins while maintaining the limb. However, megaprosthesis has its own shortcomings, such as secondary infection. It has been reported in 10 to 25% of cases in studies. Also, aseptic loosening. It has been reported in 10 to 30% in long-term cases during the studies. Chances of mechanical failure due to fracture, dislocation and component breakage. Recurrence of sarcoma. Also, it's a complex surgery associated with high blood loss, nerve injuries, and obviously the cost associated with megaprosthesis is high due to the technology being newer. Femur cortex was sufficient enough to have a cementless stem. Hence, we went for cementless stem and cemented acetabular cup, hence a hybrid total hip arthroplasty. So, considering the size of the sarcoma to be resected, age of the patient, daily activities, socioeconomic status, we selected custom-made 3D printed pelvis megaprosthesis as ideal surgical choice for the patient. For this, we contacted 3D Incredible Additive Manufacturing Private Limited company based in Pune, which has the experience of 44 years in additive manufacturing in medical devices. We provided them with NCCT pelvis with 3D reconstruction and MRI pelvis DICOMs for exact anatomical 3D printed model. We also provided them with inclination angle and anteversion angle of cuff of ipsilateral side compared with the contralateral side, so that in our customized megaprosthesis, the angles are to the exact angles which were present pre-surgery. Why? Because this would reduce the chances of dislocation at the hip joint post-surgery. So this is a video of the 3D printed megaprosthesis that we got. As you can see, these are the jigs of the iliac blade. In my hand also we have the 3D pelvis printed by the 3D printer. Here we had the iliac blade jig, here we had the ischium jig, and on the downside we had the pubis jig. These jigs were used to mark the exact anatomical location modified with the contours of the bone of the patient, so that we can have clear margins during the resection of the tumor. In the video that we are seeing, we have the titanium made 3D printed customized model which would sit at the place of after en bloc resection. As you can see, this is the live picture of the mega prosthesis. Here we can see 3 holes going into the iliac blade for fixation, 2 in ischium, 1 in sacrum and 1 in pubis. So far, we have a 60-year-old male patient with high-grade undifferentiated sarcoma with post-neoadjuvant chemotherapy size reduction by almost 39.5%. Decided for 3D printed custom-made mega prosthesis reconstruction along with hybrid total hip arthroplasties. However, such a complex surgery has its own challenges. The anesthetic challenges we faced were obesity, prolonged surgery time, and old age. The surgical challenges that we faced were location and extension of sarcoma, proximity to vital organs, and extensive involvement of ileum and ischium. Reconstruction challenges that we faced were large deficit and loss of surrounding soft tissue. With the help of his diagram, I would like to get all of your attention with the highlighted part that had to be resected. As we can see, there are a lot of neurovascular bundles and vital organs nearby. Sciatic nerve, superior inferior gluteal vessels, pudendal nerve, femoral artery, soft organs such as urinary bladder, spermatic cord, large intestines above. Hence, it was a complex surgery having vital vessels, nerves and organs nearby. Let's quickly go through the intraoperative steps that were followed for this patient. First, soft tissue dissection. We had an inverted Y incision given to the patient, and patient was taken in a floppy lateral position. Skin, subcutaneous tissue were dissected in same plane and hemostasis achieved. All the muscles and ligaments were detached and ligated. Neurovascular structures were preserved and retracted. As you can see in the images, the first image shows the neurovascular bundle which was identified and preserved. In the next image, we can see the muscles and ligaments being detached and ligated, which would have exposed the hemipelvis region. In third image, we can see the jigs that we discussed are being fixated with K-wire for temporary fixation in the right iliac wing, ischium and pubis region. Next, en bloc tumor resection was done with the help of bone saw. This en bloc tumor was sent intra-op for frozen section report, which came back with free margins throughout. Next, after confirming having free margins in the en bloc tumor, mega prosthesis implantation were done with fixation to iliac blade, ischium, pubis and sacrum. Post this, as you can see, we did hybrid total hip arthroplasty with cemented acetabular cup and cementless stem. This is the post-op X-ray. We can see the mega prosthesis mimicking the hemipelvis of the contralateral side, hence showing the wonderful outcomes of the technologies that we have with us now. We can see fixation with iliac blade, the 3 screws, 1 50 mm screw in the sacrum, 2 screws in the ischium and 1 in pubis, along with total hip arthroplasty. Now, post-operative management and rehabilitation for this patient is as important, if not more, than pre-op surgery planning and intra-op steps. On post-op day 1, quadriceps strengthening exercises, hamstring strengthening exercises, and side sitting was done for the patient. On post-op day 5, patient was discharged and was asked to come for follow-up on week 2, where sutures were removed and continuation of physiotherapy was advised to the patient. On week 6, partial weight bearing was allowed, and on week 18, full weight bearing was allowed to the patient. Patient was followed every 4 weeks for first 6 months and every 3 months thereafter. Clinical examination and relevant radiological investigations were done for the patient on every follow-up. This shows the video on 3-month follow-up with patient on walker support. We can see the hip stability as well as mobility, and patient who was unable to bear weight 1 month before the surgery is now being able to carry out daily activities without any issues. This is 1 year post-op X-ray, and we can see there is no loosening of implant, no dislocation of implants from any of the fixations, and total hip arthroplasty also being in place, hence marking the success of this surgery. Now let's quickly discuss the studies on mega prosthetic reconstructions that we referred to. First, study done by Okazaki and others in 2002. The key findings were evaluation of custom hemipelvic prosthesis after pelvic sarcoma resection. It reported high rates of infection, loosening, dislocation with relatively poor outcomes. Correlation with our case, it demonstrated the early challenges of pelvic endoprosthetic reconstruction. Despite these limitations, the study established the feasibility of limb salvage after hemipelvectomy. Take-home message: early generation pelvic prostheses had high complication rates, but they paved the way for modern megaprosthetic reconstruction. Next, we refer to the study done by Dai along with others in 2007. By this time, we had the technology of CAD-CAM, and CAD-CAM based custom hemipelvic prostheses were being done. It improved the anatomical fit, pelvic alignment, and post-operative hip function. Correlation with our case, it supports the concept of individualized pelvic reconstruction. It emphasizes restoration of pelvic continuity, limb length, and hip function, which were major goals in our case. Hence, the take-home message from this study is precise prosthetic reconstruction improves functional outcomes after extensive pelvic tumor resection. We also refer to the study done by McGoldrick and others in 2016. He highlighted the importance of multidisciplinary approach in complex sarcoma surgeries. Correlation: pelvic sarcoma surgeries require coordination among orthopedic oncologists, anesthetists, radiologists, pathologists, and rehabilitation teams. Successful megaprosthetic reconstruction depends on comprehensive perioperative planning. And we were fortunate enough to have, for being part of this esteemed hospital, and we were able to establish a multidisciplinary board, and because of this we were able to provide a successful treatment for the patient. We also refer to the study done by Fujiwara and others in 2021. The key findings were prosthetic reconstruction and modern 3D printed implants provide immediate stability and early mobilization. Alternative options such as allografts, autografts, arthrodesis, all of these had inferior functional outcomes. So correlation with our case, it strongly supports the use of megaprosthesis following acetabular resection. The study reinforces individualized treatment selection based on tumor location. So the take-home message: modern megaprosthetic reconstruction remains one of the most practical and functional options after periacetabular tumor resection. With this, we can proudly say that this case is the first of its type done in Rajasthan and one of the very few done across India. Take-home message from this case that we did: surgery. Innovations in medical manufacturing enabling patient-specific 3D planning and customized 3D printed hemipelvic megaprosthesis have enabled precise reconstruction following tumor resection, enabling excellent functional recovery and limb preservation and improved quality of life. With this, I would like to conclude by thanking first to the patient and family, to the mentors and the management, to the CCR review committee, to departments of medical oncology, anesthesia, surgical oncology, radiodiagnosis, oncopathology, and to the nursing officers and staff which help us with the patient. Thank you, everyone.